here, everyone. I'm glad to introduce Dr. Rosalind Ramsey-Goldman. She is the John P. Gallagher Research Professor of Rheumatology and Professor of Medicine, as well as the Associate Director, for the CE-ASSIST-DailyLife Resource Corps, which I think is within the Core Center for Clinical Research at Northwestern. And she's going to talk to us today about challenge and solutions in community-engaged research to address disparities in rheumatology. So I think this will be a broad topic that's really of interest and helpful to all of us. I think we'll do Q&A at the end, but you're welcome to put comments in the chat at any time. All right, take it away.
Thank you so much, Kelly, for the kind introduction. I am very excited to share this topic with you. And as part of my goal, my position in the Core is to oversee community engaged research. So this is an important topic personally for me, and I'm excited to share this with you. So these are my objectives for today. I'm going to describe the problem that we tackled for our research program. And that is that vaccine hesitancy and uptake in Black African American ancestry individuals who already have an increased risk of this infections in general. And this is a particularly serious problem for individuals who have rheumatic and musculoskeletal diseases. And the next background piece I'd like to review with you is to explain the community-based framework that we used as a strategy to mitigate healthcare disparities and inequities in care, focusing on vaccines. And then we will describe, I will describe our research plan for our R01 NIAMS funded study called Activate. And I'll explain what that mnemonic means. And in the context of writing the grant and after it was funded, we had to deal with challenges and solutions to actually operationalize Activate. And I'm just going to specifically talk about the development of the study materials and the collaborative interactions that we had with the IRB in order to actually move the trial forward. So first, I'm going to talk to you about the problem that we decided needed to be addressed. And this is persons with rheumatic and musculoskeletal diseases have an increased risk of COVID infection and adverse outcomes. So this arrow is meant to illustrate increasing risk for individuals. And so if you think about people in the general population, they have a risk. This risk is increased if you're unvaccinated in the general population, and this risk is further increased in unvaccinated individuals who have rheumatologic and musculoskeletal diseases. This increased risk for infection in patients or persons with rheumatologic and musculoskeletal diseases is increased at least 1.5-fold over the general population. And in addition, they have an increased risk for adverse outcomes because of severe disease, plus their comorbid conditions, as well as the medications we use, such as steroids, methotrexate, and B-cell depleting therapies. And in additional studies, an independent risk factor, which is important and pertinent to the study today, is that those living in low resource areas also have an increased risk of infection. So on the right-hand side, what I'm going to show you is the percentage of Chicagoans who are up to date with their COVID-19 vaccinations by demographic group. You can see that I have the date as May 2024. I actually checked the website, and the last official data they have is from the end of August of 2024, because they're not reporting this regularly these days. And I would say that the figures that were listed in August are very similar to what I'm showing you here. So citywide, about 16% of people are up to date with their vaccinations. If you look on the left-hand side of this panel, you see that vaccination rates increase with increasing age. So the youngest have the least amount of vaccinations, and the oldest individuals are doing the best in terms of getting their vaccinations. If you look a little bit to the right, you see that men and women have about the same vaccination rate. And then pertinent to this discussion is the self-designated race and ethnicity of individuals, and the group that has the lowest vaccination rate are the Black non-Latinx individuals. I would say that just in the last week, the Chicago Tribune, which is the local paper, says that the citywide vaccination rate as of now is about 11%, with a similar distribution of who's getting vaccinated. So because of the increased risk in the population that we deal with, our recommendation would be that you should get vaccinated. And also think about the cocooning concept, which means those around you should also get vaccinated because they're living with high-risk individuals. So this is forming the background of why we decided to attack this problem. And these are the references that I'm quoting here on all of these statistics. So why did we want to do this, and what were our challenges? Well, there are multifaceted reasons for COVID-19 vaccine hesitancy and reduced uptake among these individuals with rheumatic and musculoskeletal conditions, which stem from misinformation, lack of physician or other provider recommendations, fear of disease flare, mistrust in the healthcare system, and prior and current experiences of racism. And so we were trying to solve this, and looking at this through an equity lens allows attention to group and individual experience differences in risk, needs, opportunities due to legacies of inequity, injustice, and discrimination. And the intervention needs to focus on the needs of the populations that are historically marginalized or vulnerable to prevent widening already existing inequities. So there have been several strategies, multimodal in the hospital, such as using reminders in the electronic medical record. And another strategy which we employed was a community-based strategy to provide education and build trust with the goal of improving vaccine uptake and reducing existing inequalities. So this begs the next question, which is why is it important to involve both communities and academics in research? And first, I just want to level set us with some definitions. So when we talk about healthcare disparities, we're talking about healthcare outcomes between groups. And when we talk about inequities in care, we're talking about differences in social, economic, or environmental resources. And another way to think about this is in the social determinants of health. So when we do work together, communities and academics, the bidirectional involvement is important. This helps align priorities, recognizes the community identity, builds trustworthiness so that you can be trusted and there's trust between the community and the academic partners. It facilitates input on study design, development of the intervention and the implementation of the intervention, assistance with health literacy, navigation of the healthcare system, and also dissemination of findings. So in this context, I'm going to tell you about our community academic partnership framework, and I'm going to refer to that as CAPS throughout the talk. And then using the popular opinion leader model, I'll refer to that as POL or POLs, as a strategy to reduce the risk of COVID-19 infection and adverse outcomes. So why are we talking about CAPS? So the problem here was that research in the controlled research environment many times fails to translate into a real world environment. That's why CAPS were developed to try to overcome research barriers by formalizing the relationship between academia and communities to create a more realistic and effective intervention. And this allows for varying degrees of community engagement and to develop a sustainable structure. So these are the important features of CAPS which facilitate those goals. We build on the strengths and resources and social networks within communities. We empower communities to reduce social inequities and to address social determinants of health. This enhances the study design and the dissemination of the healthcare intervention, and it fosters trustworthiness and creates trust. And it facilitates dissemination of findings and opportunities for co-authorship. So this is the CAP that I am proudly part of and privileged to be part of. That's funded by NIAM, the NIAMS Institute and the NIH, and my partner, Dr. Candace Feldman at Brigham and Women's Hospital. And what you see here are the elements of the community academic partnership. The lead academic organizations are Brigham and Women's Hospital and Northwestern Medicine, Feinberg School of Medicine. And we also have our colleagues at Boston Children's Hospital to get the young adults, and Boston University, which is a safety net hospital in Boston. On the right-hand side, you see some of our community partners. Women of Courage is a support group in Boston. Helping Communities Help Themselves is a support group in Chicago. Alliance Chicago is a group of federally qualified health centers focusing on primary care that are our partners. And the Lupus Society of Illinois support groups are our partners. What I haven't listed here due to individuals' preferences are individuals in public health, in the public health sector, and other advocacy groups that did not want to be listed specifically. And you could see that the overlap between these two groups has two goals. We want to improve health and we want to reduce disparities. So now we'll focus on the popular opinion leader model, which was our strategy to try to work with our intervention. So the popular opinion leader model is a community level intervention that's approved and used by the Centers for Disease Control and Prevention, originally targeting individuals at risk for HIV and also to get those individuals tested and treated. A popular opinion leader model is designed to influence norms, behaviors, intentions, and to prompt actions in a specific community. It uses the POL social network that includes a set of individuals or organizations who share common interests. So how does the popular opinion leader model work? And so it improves norms that have been causing damage or threaten welfare of the community. And examples would be delaying in getting healthcare or access to care, misuse of resources, and misunderstanding of recommendations for healthcare. Popular opinion leaders endorse various well-intended causes in different venues through engagement with their social networks. And POLs are innovators who endorse the advancement of knowledge, influence all beliefs about disease, and dismantle stigma around vaccine uptake and hesitancy as particular goals for this study. So what is a popular opinion leader network? And I'll also refer to this as social member network. So here you have an example of how a POL might reach with their social member network partners. So the POL is in the center. You see there are a lot of other people surrounding the POL. If you look at the brownish orange line, that means that the POL has a strong connection with that individual or within individuals. And the blue lines are weaker ties, but you see overall the network can work together in order to inform the community and help them make better decisions about their healthcare. So I just want to talk about a few discussion principles about how all of this works, because there are certain ways that you would be working within your communication strategies to make the interaction between the POLs and their social network members work. So these are things that I've heard over various meetings about community engagement. And so one of the things that came up in a talk was to look at the words listen and silent. They're the same, use the same letters, and they can have multiple meetings. And these are at least two important concepts in community engaged research, because it's important to understand the lived experiences, and our PLLs will do role playing as part of their training, and how you deliver the message is important. So it's important to listen to the lived experience. And so that means giving that person time and being silent to absorb what they're telling you, especially and to be respectful, because it might be a difficult discussion. But silent also means that some people have not been heard and that they've not been able to share their lived experiences. And this is contributing to difficulties in assuming or learning about new healthcare behaviors. The next concept was trustworthiness versus trust. And this was brought up by the director of the Tuskegee Ethics Institute. And he asked the question, why should I trust you? You show up in my community, but why should I trust you? And he wanted to illustrate the difference between trustworthiness. Are you really interested in my community? Do you really care? Or are you just here for the research and it's one and done and you'll be gone? And to be more effective, you have to demonstrate that you are trustworthy. And you could see that sort of an underlying principle of the popular opinion leader interaction. And this will actually become important when I talk about some IRB challenges. And the last comment was a different definition of race by a talk that was just given in our health equity symposium a few weeks ago. And here, when we talk about race, we try to make sure that people understand this is a social construct. This is not related to biology or genes, and it's related to your lived experience. And the way he described it is race is how a person is experiencing living in their country. So just think about this in terms of the importance of how we have to be delivering messages and have our bidirectional interaction between academia and our communities. So now I'm going to segue into the actual trial that we have designed. And again, I'd like to acknowledge my partner at Brigham and Women's Hospital, Dr. Candace Feldman. And the official title of the project and the application was Levering Community Academic Partnerships and Social Networks to Disseminate Vaccine-Related Information and to increase vaccine uptake among Black individuals with rheumatic diseases. So that's a mouthful. And so we came up with a logo, Activate, and a graphic to get everybody on the same page and to unite all. And even though the explanation for what Activate stands for is quite wordy, I think people will focus on the Activate part of it. But for completeness, I'll say that Activate means academic community partnerships to increase vaccination in Black and/or of African descent identifying communities. And again, my partner and our funding. So very briefly, I'm going to tell you about the specific aims of the project. And so aim one was to leverage the CAP partnership across 2 US cities, Boston and Chicago, to develop training and evaluation materials for our popular opinion leaders, or POLs. And I already showed you what our CAP looks like. And just to reprise that, it's a network of community leaders, rheumatology advocacy groups, public health organizations, patient advisors, and physicians who develop the POL training curriculum and evaluation materials. And I mentioned before that the importance is how we were delivering the message, and it's with and without racial justice framing to address vaccine hesitancy. In the original grant, we were supposed to accomplish all of this in 1 year. It took us 2 years to complete this aim. And just to give you an idea of where all of this work is going to go, I'm just going to talk about what part of what aim 2 includes. And that is to establish the efficacy of the community-based popular opinion leader intervention with and without the racial justice framework to increase COVID-19 vaccine uptake and reduce hesitancy among the social network members of Black individuals with rheumatic conditions. And there were two arms to the study. The basic core material is the same in both of the arms, which includes vaccine hesitancy, safety, and efficacy. Arm 1 is the intervention, and the training is enriched in critical race theory, embedded in every training module, acknowledging and addressing the role of racism in vaccine deliberation and stressing vaccine uptake as a form of social justice. And this is protecting the community. Whereas Arm 2, which is the control, focuses on a biomedical model of prevention and focuses on the individual's healthcare practices. And then following the training, the POLs will disseminate information through their social networks, focusing on Black individuals with rheumatic conditions. And the hypothesis is that the social network members of the POLs who receive the vaccine safety and efficacy training with the racial justice framing will exhibit better or greater vaccine uptake, decrease their hesitancy compared to the network members of the POLs who are not trained with this lens or with the prevention model. And so we're currently in year 3. And so this part is ongoing. So we're just about ready to start the intervention. Hopefully we will have some results for you in the next year or 2. So this is just a schema of the intervention design. You see there's 3 parts to it: recruitment, training, and the trial itself. We'll talk a lot about the challenges in recruitment and developing the training. And as I mentioned before, we're just about ready to start the trial in the next month. You see there are 2 parallel tracks with popular opinion leaders recruited in Boston and Chicago. They're randomized by age and gender. Each city has randomization into 2 arms. Arm 1 is the intervention with the racial justice and vaccine safety efficacy training framing. And Arm 2 is the vaccine efficacy training with the prevention training strategy. And we're actually going to combine the 2 cities. Arm 1 from each city will be trained together. There'll be an evening and a weekend session, and the same will happen for Arm 2. And once they are trained, if you just look at the light blue bars, the POLs reach out to their social network members to collect baseline data, disseminate the vaccine information. They talk to them at least 2 times. And at the end of 4 weeks, after a second contact, they collect information about vaccine uptake, and also at both times the social network member fills out a survey about how they feel about vaccine hesitancy. The part that I'm not going to talk about is the dark blue where it says aim to be, which is looking at how the social network is set up by the POL to see if that has any impact on the outcome of interest, which is vaccine uptake and increased vaccine uptake and decreased vaccine hesitancy. So now I'm going to segue into the challenges of how we had to operationalize all of these things that I told you about that were based on previous work. So our CAPs in both cities had lots of input, and this is what our original recruitment flyer looked like. We had been dealing with the IRB in terms of looking at what was required for recruitment materials. And you needed to say a lot of things about your research. What are you doing? Who participates? How long do you participate? What's the benefit, compensation, risks, and contact information? And so this rolled out in April of this year, and it was a total dud. In 1 month, I think we probably did about 3 recruits. And so we went back to our CAPs and wanted to troubleshoot. In the meantime, we had also asked our coordinators who were doing this intake what kinds of challenges they came up with. And so this is the benefit of the CAP, because we got a lot of feedback about how to improve recruitment. We'll focus first on the flyer. And so I'm going to share 6 different things that were discussed over many meetings with people in Boston and Chicago, where we either talked only to the community. Sometimes the meetings, just for convenience, included both the academic and the community partners in each city. And then one of us from Chicago will listen in on the Boston meetings, and the Boston meetings will listen in on the Chicago meetings. So the first thing was relatable imagery. The flyer needed to include a diverse and more representative group of people in a conversational setting, making it more community-oriented and relatable, rather than using, the logo. They also suggested that we use more inclusive language. The eligibility criteria was revised in the flyer to say Black and/or African descent, instead of listing specific groups that we were targeting in Chicago and in Boston: African American, Black, Cape Verdean, and Haitian. And this change broadened the inclusivity to all individuals of African descent, making it more welcoming to a wider audience. We also simplified the header. We said, protect your community's health. It was more straightforward, action-oriented, that speaks directly to the audience's sense of community. Additional information was streamlined. The layout in the new flyer is much more compact and focused, with just the essential details on participation and compensation, and we made it easy to find that information. We added direct contact and a link. This flyer included not only a URL link, but also a QR code, which led to an interest intake form that the person could automatically put in their contact information and their preferred method of contact, so that the study staff had a way to retain this information and facilitated contact between the prospective POL and our research staff. And finally, visual balance, or how everything was displayed. The new flyer shows a curved design element to guide the eye smoothly from title to content, providing a more inviting visual flow. And if you remember sort of the horizontal busy slide that I showed you before, this is the new slide. And it made a huge difference. Once this was approved by the IRB, and by the end of June, I can say that we're almost 85, approaching 90% recruitment, which means we are likely to start in November. And so this was one example of how the CAP really made a difference in terms of one of the most important elements of doing the study, which was recruitment. The other piece where there were concerns, particularly from the community, was the script that we developed for our coordinators when a prospective POL called in. And the sticking point was when somebody did not qualify. So the original script, when a POL did not meet eligibility, stemmed from the answer to the question, have you received at least one COVID-19 shot after August 31st, 2022, bivalent booster or the updated vaccine formula? And if the individual was not eligible, the answer was pretty short. Thank you for answering our questions. It doesn't look like you'll be eligible to participate. We appreciate your time. Do you have any questions? If not, we wish you a good day. And the coordinator said that this was kind of awkward in the conversation. And so we brought this back to our CAP, and the immediate response, even though we had showed the original script before, was, boy, that sounds kind of cold and terse. And, you could sort of cut the conversation off. And it might actually perpetuate feelings of not belonging or being less important, which is certainly not the message that you want to share with a community that already feels marginalized. So I realize this is a busy slide, but after a lot of input, the main change was transparency. It was really important to tell people why they did not qualify. And so the change here is thank you for your interest. You're not eligible. This study requires that POLs have received a COVID booster or the current COVID-19 vaccine for this season. Since POLs will be sharing the COVID-19 vaccine-related information with their family, friends, and community, we want POLs to be able to share their personal lived experiences with receiving the vaccine with their social network members. We really appreciate your time. And these people who called in at least had expressed some interest in participating in research. And so we wanted to acknowledge that. And so we asked them, are you interested in participating in other research studies? And if they said yes, we were able to direct them to websites in Boston and in Chicago that list other potential options. We then ask again, do you have any questions? If not, thank you, and we wish you, excuse me, a good day. And again, this seemed to work much better in terms of actually establishing a relationship and trust, in terms of being really interested in these individuals. And even though they didn't qualify for this one, maybe they would think about other research studies, and this would not be the only study that you would want to increase the diversity of your recruits. Next, I'm going to talk to you about developing the training curriculum. And so just to refresh your memory, the objectives of the two virtual curricula were developed using theoretical frameworks. First, focus on the center. The core curriculum included education about the significance of COVID-19 infection in individuals with rheumatic diseases. It describes the COVID vaccine and booster development. You respond effectively to the misinformation about the vaccine and boosters, and they needed to understand research procedures, including privacy, confidentiality, and informed consent. Now, please look to your right where we use describe how we use the racial justice lens. And here we discuss historical and current racial injustices within the healthcare system. And we describe corrective measures in the healthcare system that has been created to deal with those injustices, and also include that it continues to develop and address these issues because they're ongoing. Now turn your attention to the left with the biomedical lens, and here the main messages communicate the importance of the COVID vaccine as preventive care. So I'm going to talk to you about the iterative process of the curricular development. Again, the strategy used a CAP with the popular opinion leader model to work within communities. We developed two curricula with and without racial justice framing. The process was iterative development that was based on literature review, as well as structured interviews with CAP members. And what we were testing was the messaging strategy and how it impacted income, decreased hesitancy, increased uptake. So we have the iterative curricular development here. And if you'll start over here, we did an initial development of materials. We sent it to all the CAP members and we gave them a worksheet to make comments, but we also held virtual meetings. So we had two methods of getting feedback from CAP members. We incorporated their feedback into materials. We planned the next visit after revising the curriculum materials. And this process went on for almost a year as we worked with all of our partners to develop the appropriate materials and also to keep track of new information and recommendations about a vaccination. And I'll just say that this particular part of the talk will be presented in a poster by one of our fellows here at Northwestern, and it's posted 1907 on Monday morning. And this manuscript has been submitted. So I'm going to give you examples of how the curriculum changed dramatically. And so the first thing that I want to talk to you about was feedback regarding literacy level. And so the academic side went ahead and developed the slides. And they felt it was really important to give lots of information about vaccine mechanism. If you can see on the left-hand side, you probably can't read it. That would also tell you that this is not something that would go well in training and keep people's attention when you're trying to work within communities. This is not meant to talk down. It's just an ineffective way of delivering the message that you want to deliver. And so see all those words here? Now I'm going to show you how it ended up. And we wanted to get straight to the point about what the vaccine does, how it works, and what it might mean in terms of getting the vaccine. And also included the graphic to illustrate these points. So what we wanted to say was, how does the vaccine work? It provides the body's immune cells with information to fight future infections. The immune cells need time to develop this response, so you could still get the virus after vaccination. And I would add that you could still get infected, but the main goal here is to mitigate the severity of the disease. And we also acknowledge that there are side effects, but that it means that it might be working and they are transient. You can see on the graphic that you have your virus with its spike proteins, and the shield, which is your vaccine, prevents it from getting into the cell. And we thought that this communicated the most important message, and this is the dramatic change in how we had to revise the curriculum. Next, I'm going to show you an example of another underlying theme, which was the tone of the slides. So we wanted to acknowledge that there's mistrust in medicine and in equitable care. We need to be transparent about what the challenges might be. And we talked about the difficulties that Black patients might have across several of our diseases. But the main concern from the CAPS was that the graphic was very negative. And if you want to get somebody to go feel empowered to change somebody's thinking about a vaccine, this was not the ideal situation to talk about bad things, but to empower people that you can overcome the bad things. And so here is the end result. Again, we needed to be transparent about what the differences might be and the barriers for Black patients as they seek other care. And we list some of the challenges. But the main change is the graphic. We wanted people to feel empowered that, yes, you can have a good conversation with someone. It's not like it's all negative, but you can move forward, and important to have that kind of dialogue and how to have that dialogue with your provider. Now, I'm going to show you the curriculum. Again, another busy slide, but I just wanted you to see the extent for how we would develop the racial justice lens and the biomedical lens. There's a lot of important information. The difference is how the information is framed. I'd like to call your attention to Module 4, which was the main difference, where structural racism, race inequalities, and infection risk and preventive care and uptake is discussed. We talk a lot about discrimination in healthcare, historical injustices in research, as well as the current ones and the protections in place for patients. In general, preventive care, we discuss unhealthy practices and give examples of preventive care, of which vaccination is part of that. In Module 4 is the required research subject training, which I'll talk a little bit about again when we talk about the IRB, but everybody gets the same training. And importantly, the ending Module 6 is review of all the material and role play with common questions. So we teach people how to have these conversations, including difficult ones. We use examples such as storytelling, direct language, and iterative conversations. And we do role play, specifically making sure they know how to consent and disseminate the information. And in the racial justice section, all of the conversation starters have the racial justice framing. And in the preventive medicine, the conversation starters have preventative care strategies. We also needed to test knowledge, pre and post test questions. Again, busy slide. I'll just give you the ideas of how we did evaluation, which was based on our previous experience working in the lupus conversations programs between Boston and Chicago that were funded by the Office of Minority Health, where our communities said that when you ask us questions, we feel like we're getting a test, and it makes us feel uncomfortable, specifically when we had multiple choice questions. And so what we did was said, the test is really not a test. It's another way to help you learn. But because there was problems with how people felt about multiple choice questions, we added open-ended questions, which we thought might be more helpful for individuals. And that's how this all evolved. So all of the modules, really, people don't get a test score. However, for research methods, we needed to make sure that people were competent to human subjects work and confidentiality. And so in this case, there is a benchmark of around 70%, but we would be prepared to work individually with POLs who might struggle with this, because this was an important element that I'll talk about in the next section on the IRB. Again, underlying all of this was listening, being respectful for silence, but understanding the lived experience, making sure that our POLs were trustworthy, and that's the underlying premise of the popular opinion model. And that was very important to share the lived experience. What is it like for you in your community? So the last part is to talk about the IRB challenges and the solutions. So the CAPS and the IRB worked collaboratively to address two specific challenges. The concern was the dual role of the POLs as study subjects and also extensions of the study team, and how we did the consenting process. So within our two-city group, each city accepted one of the administrative tasks for the trial. So Boston worked with the IRB, and Chicago did the database setup and data management. And so in preparation of the IRB application, our PI, Dr. Feldman at Boston, at Mass General Hospital, worked with their IRB. And we assumed, as did they, that we needed a single IRB. We would be a non-exempt study because we were a federally funded, a randomized controlled trial. And the issues came up concerning POL interaction with social network members, because consent was implied by their willingness to engage in a minimal risk conversation rather than actual written consent. And was that okay? And the concern between the POLs as study subjects, because they were trained and we evaluated them and collected data on them, as well as they were members of the study team that were actually delivering the intervention and collecting the data. Once the IRB heard this, they said, we think the POLs need to take human subjects training, including the Belmont report, consenting procedures, how to collect data confidentially, including HIPAA, and maybe even some parts of the GCP training. The IRB also wanted the POLs to sign an extensive investigator agreement, which also included how they were going to be compensated. So we shared the IRB feedback with the community and academic partners as we were developing the IRB application. And this is the feedback we got from the community partners, and these were their concerns. They felt that there was actually a conflict of interest for the POLs because they were research subjects and they were going to be paid to collect the data for the study. But the next two parts were the most important. They emphasized that POLs are community members. They're not an extension of the academic research team. And the most important point was that the POLs were following researcher rules, which would inhibit the social norms and dynamics of the interactions with their social network members, which would impede their impact and their reach and could compromise the study. So we felt that we had a very good relationship with the IRB, so we shared these concerns with the IRB, written in a letter by the Boston PI. And this is the revised decision and the recommendations that the IRB made. They reclassified the study as exempt, and it was a low-risk behavioral study. Therefore, a single IRB no longer applies for exempt studies. So that meant that all the sites needed to get their own IRB approval, which of course resulted in delays. The POLs were required to receive appropriate human subjects training. So we developed our own training and evaluation metrics, shared it with the IRB, and they approved it. So this training was specific to what they needed to know for the kind of work that they were doing, not the overall human subjects training that's required in academia. The IRB also required us to prepare a flyer. It states POLs work with community organizations, hospitals in Boston and Chicago, describes what study participation involves, and it needed to include an IRB contact. And when the POLs agreed to be in the study or the social network members agreed to go in the conversation, the completion of the first survey served as implied consent, and we did not have to have written consent. All study data was captured directly into REDCap so that no POL was actually handling data. So in conclusion, the unique nature of the CAPs using a validated community and engaged study design, the popular opinion leader model, had the potential to reach a diverse population often hesitant to engage in traditional research aiming for reduction of racial inequalities and COVID-19 vaccine uptake and hesitancy. Our longstanding CAP was essential to developing culturally relevant trial materials. Collaborative interactions with the biomedical IRB, who had limited experience with community-engaged research, resulted in delays and modifications to the original plan. And because we were minimal risk, it allowed the IRB to approve this as an exempt study so it could be consistent with the project's original goals to maximize community engagement. These are the references. Just again, all of these are published except the last one on the list, which currently is under review. But you can see the details of this in poster 1907. And I'd like to acknowledge the funding and all of the partners that are participating in our CAPs. Thank you. I can stop sharing. I'd be happy to answer any questions.
If I could jump in.
Yeah,
thank you. That was great. Thank you so much. We are, I'm working with a group. So we have a board, a community advisory board that's made up of some patients with osteoarthritis, some representatives from community organizations that could deliver the program that we're developing, some consultants that are on our research team that have bridged between academia and the community in the past. And then we invite our co-investigators, so sometimes they attend. And our meetings go well, except a lot of our patients never speak up or speak up just a small amount. And I call them out and I try different ways, and I can barely get a few sentences out of them. And it's really I mean, I really want to hear from them. And so that's question number one. And then number two, what do you do when you get conflicting reviews of how you should change things or how you should approach something from your
Okay.
board?
Yeah. So, basically we have our own board for our study, but actually my job in the P30 is to be the co-chair for our CAB, which would help other people's studies like yours. And so we've actually had the CAB participate twice. Not everybody speaks, so we have the same challenge. But my co-chair is really terrific. And she's like texting me, chatting with me. And the part of the problem was jargon. And we as academics sometimes use words that are not relevant. And so we interrupt the speaker and say something. And we also decided that when we get somebody's presentation, we call it our symphony meeting when somebody's asking for our advice, that the co-chair and or myself, so far it's been me mostly, translating all the study into lay language. And we are working at both ends. We're trying to get the academic presenters at this meeting to be mindful of the audience and the differences of things, and then also coaching the CAB members who attend to ask questions. So some of them have experience in research, so they are, already feeling like they have agency and they can talk. But I think interacting with our CAB members to help them speak up is also going to be important. And as I said, we've only done this twice, but the goal is to have our own sort of CAB debrief to get, what their concerns were, how we can help them as the co-chairs help them. So, your comment is very appropriate, and we're struggling with that too. Our CAB, just so you know, our people are not shy at all because we've been working together for almost 10 years. I sort of had a skewed view, but as soon as we had our first meeting, which was not specifically related to my study, immediately the co-chair is texting me jargon, and it's just like an eye opener. The other question that you asked about, conflicting reports. We have difficult conversations. I think the important thing is to listen and see what the concerns are. And then the sort of leadership team might go back and try to synthesize everything and reach a compromise or a consensus. But before we make a change, we let the CAB members know, the CAB members know. So you're going to have conflict. In fact, if you're really interacting with your community and there are disagreements, then that's actually a good thing, because that means that you are not agreeing, and you're looking at it from two different lenses. So actually, I would view that as an opportunity to listen and get out of your own silo and think that there might be another way to do it. Because if you're only coming at it from your angle, that's going to compromise your success in what you're going to do. So yes, we've dealt with both of those. But this is where the trustworthiness comes in. You can say something that you don't agree with, but you are respectful about that opinion and you acknowledge it.
Thank
Yeah.
you.
We have a few more minutes if there are other questions. I just want to say I really appreciated that thorough description of what you all did. I think, we often read the papers and brief descriptions, or read a little bit more of a description, but don't get to hear kind of the nuts and bolts of the whole process. And it's certainly a challenging one. So it's encouraging to see how rigorously you all did this.
Yeah, it really took much longer than we thought. And I would say our funder was very respectful. And actually, we documented each step because, particularly with the IRB story, We talked to other colleagues who do community engaged research here, and they said you got to publish what you did with the IRB because that took 8 months of negotiations back and forth. And even though you could say it was frustrating because it held up our funding for the second year because we had to have IRB approval for the trial. I think in the long run, it was very helpful and actually is going to enable us to do it. And if others can benefit from that kind of conversation and collaborative work, I think it will make community engaged research much easier to include in your research portfolio.
Yeah. Do you have any tips for maybe early career researchers or just somebody who is getting into a new area and they don't have the kind of funding or time that you did for this project, but they are maybe doing preliminary studies and they would like to make sure they're having this kind of approach built in from the beginning? Any tips on how to do that when the resources aren't quite so much?
Yeah, I'll give you 2 examples. Number one, that's exactly the part that we've added to what we call our symphony meeting, which is people bring applications at various stages, and we really try to work with junior investigators to help them formulate this. And this year, we have them fill out, well, in the last year or two, we've had them fill out a questionnaire about community engagement. And we also attend those meetings and make comments. It's very clear that there is a knowledge gap about community engagement, and that part of what we have on our resources is how to do that, and then we offer ourselves to help. So yes, that is a problem, and it's now built into our meetings to help young investigators. The other thing is, personally, Candace and I have worked with fellows, residents, junior investigators, and we are mentors to junior faculty, and we support them. And if you look at the reference list, I think almost every single publication is written by one of our mentees. And they're a diverse group of mentees. And just to go back to the first part about our symphony meeting to help investigators, we also review the proposals before they're presented at symphony. And if it's your interest area, which includes, let's say, community engagement, they'll ask us to look at it ahead of time. And sometimes we do an individual symphony meeting with the person because it's not even ready or mature enough. And 2 of us are now going to be mentoring a junior investigator who has some background, but we're going to link them with the disease of interest, their outcome of interest, and use our context that we have developed over time to include the community, which is an essential piece of this particular project. So we try to touch people in various different ways, either personally or through our P30, to actually address the problem that you mentioned. And I think it just has to be out there.
Yeah.
People who do clinical research have a general idea of this, but certainly the basic science people don't. And that's like a new concept for them. But even those who are doing clinical research need the context, and that's what we provide, is the context to where they could get the information and make them think that this is something important that you would want to share with others outside of the academic silo.
Mm-hmm. All right. Well, this is great. Thank you again. We really appreciate your time and sharing your work with us. And this will be recorded, and I think an email will go out. So if you have colleagues who weren't able to listen in, please feel free to share that with them.
Thank you.
Thanks again, everybody. Good to see you.
Thank you for the invitation.
You're welcome. Bye-bye.
Happy to answer anybody else's questions offline would be fine.
Great. Thank you.
Okay.
Bye-bye.
Bye.